talk to you guys about kind of this stepwise fashion until we get to the really bad situations for a patient with hypoxic respiratory failure or somebody that's progressing towards what we would just describe in our documentation of acute hypoxic respiratory failure. So we're breathing what?
20%.
How much?
21%.
21%. So that's room air is 21% oxygen, correct? Okay. So now all of a sudden, it's a young, normal patient. They don't have COPD or pulmonary fibrosis or underlying lung issues. All of a sudden, a patient now is desaturating. What's kind of like the first move that like literally everyone inadvertently, for whatever reason, has in the hospital that's like completely unnecessary? What's your next step? Yeah, like nasal cannula oxygen, okay? So that's the little oxygen things in your nose. And then how is nasal cannula measured? In liters, right? So typically someone starts of like 2 liters of nasal cannula oxygen. That's like a classic one of a geriatric patient sitting in the trauma ICU, right? My question though is, what's the change in the FiO2 of this person on 2 liters? Do you guys know the answer to that? 10, 20 what? Percent? So it's really every liter is like 2 or 3% of an increase. So this really is like, I don't know, 4 to 6% of an increase in theory over to here, okay? So something to think about. What would be kind of the next step after nasal cannula if someone's still not doing so great? So that's maybe a little further considered because a non-rebreather is like a mask that has a bag on it and we're delivering as much 100% as we can. So that's kind of a little further down the line to where now we're almost talking like, because what's my like kind of fork in the road here? Yeah, a ventilator, right? So intubating the patient and doing mechanical ventilation. So this is what we would call invasive. And then over here, we would say these are like non-invasive forms of ventilation or oxygenation or oxygen therapy. So kind of end of the line from like a non-invasive, but there's something we can do that's also non-invasive that's even a step further from here. There's kind of 2, I think. And so let's put more in here of like venti mask. Have you guys seen that or do you know what that is? That's just a face mask and you can adjust the FiO2 on it. So you can go up, like sometimes somebody would be on like 40% on a venti mask. So now we're getting kind of high in our FiO2 realm. So then all of a sudden they're not doing so hot. That patient that coded, if you didn't have anything, yeah, you could always slap like a non-rebreather on somebody to try to help deliver more oxygen. What are like 2 more things that I'm thinking of over here that are even kind of next level? Actually, I'll put one over here. So we have because you guys might not know this. So we have what we call high flow nasal cannula. Has anybody seen that? So you set how many liters you want it and the FiO2. To me, it's another one of those kind of salvage, like we're getting close to not doing so great, but it's also good to go from here to here. I like that a lot. So I extubate somebody to high flow nasal cannula. Pretty good, works well sometimes. What's like non-invasive but still considered mechanical then? There we go. So now that's what I was looking for. So I wanted either CPAP or BiPAP. So these, now we're actually pushing air into the lungs because at the end of the day, what does a ventilator do?
Pressure.
Pushes air into your lungs. That's the beauty of it. So everyone makes this super complicated. It's not. You're pushing air into the lungs. So someone's failing, not doing so great. Maybe they failed miserably and had to go straight to here, okay? Or maybe it was like this progressive kind of, not chronic, but like, they weren't doing so great. We tried to salvage them, we couldn't. So now we're on invasive mechanical ventilation. My question to you is, because the second you intubate somebody, you just intubated that SIM patient, the respiratory therapist is going to say, what vent settings would you like, doctor? So what are the 4 things that you need to tell them you would like? Okay, respiratory rate.
FiO2.
Okay, FiO2.
PEEP.
Okay, PEEP.
And tidal volume.
Good, and tidal volume. Okay. Which two affect the ventilation and which two affect the oxygenation?
FiO2 respiratory rate is.
Ooh, we already mixed them up.
Never mind.
Think minute ventilation. What's the formula for minute ventilation?
Respiratory rate times tidal volume.
Yeah. So these two affect what?
CO2.
Ventilation. Okay. Blowing off CO2. Think of it. More volume blowing off or faster blowing it off. Okay. Ventilation. What about oxygenation? Other two. Okay, so we can give you more oxygen. What's the most oxygen we can give you?
100%.
100%. Or we can increase your PEEP. What's PEEP stand for?
Positive and expiratory pressure.
Yeah, or we can give more PEEP to help stent and keep the alveoli open. Okay, and these are going to affect oxygenation. Okay, what are the things we look for then to get rid of this thing and move towards extubation?
You can see there's spontaneous breath.
Okay, so they have to be on a minimal support, and that would be what I call PSV, so just pressure support, okay? So they're only on pressure support. We're giving them pressure to overcome the fact that they're breathing through a straw, which is the ET tube, okay? Because you would tire out. If I just put that up to you, that would suck, right? So literally. So you need some positive pressure, okay? So they're breathing on their own. What about their mental status? What GCS would you want this patient to be if you were going to extubate them?
Above 8.
Okay, less than 8, intubate, so good idea. But if I had a patient with a GCS of 9, probably not a good idea. What's the max GCS that this patient can be?
Oh, because he can't speak. Or they can't
There you go. So what do you get for verbal with an intubated patient? You get 1 T, okay? So then I have a patient who's 1 T because of verbal, because there's a tube in their mouth. They're a 4 for eyes because they're opening their eyes spontaneously. That's 5 T. And then they're following commands, okay?
So 6 for motor.
So 6. So what is this patient who I am feeling safe and wanting to move towards extubation? What is their GCS? 11 T. That's what I want to see. Somebody on a ventilator, I want to see them at an 11 tango, 11 T. Because they're sitting there looking at you being like, dude, take this thing out of my mouth. I'm like ready. That's the optimal patient, okay? What's another thing we get on most patients every day that are intubated?
Chest X.
Yeah, chest x-ray. So we want to make sure there's nothing structural that's going to hold us up. Is there a pneumothorax? Is there a large hemothorax still? Is there something going on here? Okay. And then has anybody ever heard of the Tobin index? Do we know what that is? Okay. So what you need it to be is a good number. So it's like they say less than 105, okay? So you want somebody who's breathing really deep breaths at a slow rate, okay? So if someone's breathing 100 times a minute and they're only breathing 100 cc's, you're in big trouble, okay? Versus the patient that I want to extubate who's taking nice, slow, large volume breaths. That is somebody who has a nice chance of flying, if you will, after we extubate them. Okay? Does that help?